Hi, good morning. My name is Stephanie Morris. Today we're here to discuss atrial fibrillation. We will touch a little bit on pathophysiology, and we will compare and contrast two drugs, and we'll talk a little bit about lifestyle and maintenance after. First off, let's talk about pathophysiology. Normally, our electrical conduction of the heart generates a QRS complex. So this is when the AV node fires, the electrical impulse travels across the heart to the AV node, and then down to the Purkinje, all the way down to the Purkinje fibers. This initiates a contraction of the atrium, and then a contraction of the ventricles. When we have atrial fibrillation, what is happening is we have multiple foci on the atrium firing, causing it to quiver instead of having just one big contraction. So two of the drugs that we can do, we're in the drug class of antiarrhythmics. One of them is sotalol. Sotalol kind of has a couple of, it's a beta blocker, but it also has some other effects as well. So the job of sotalol is to change the timing of the electrical impulse across the heart by changing the electrolyte pumps on the heart. So it's trying to slow it down so that when it can slow the generation of the impulse through the heart. So then not all of those multiple foci are getting through to cause the contraction. So when we're giving this drug, of course, if we have other drugs that are trying to generate the same effect, they can potentiate and work together and make a situation much worse. We can give this medication orally. It's well absorbed, and it has 90 to 100% bioavailability, so it works pretty well. Of course, caution in giving with other drugs in this class. It's about $70 for 30 pills, according to GoodRx, and that's without insurance. And of course, we're trying to restore a normal sinus rhythm. Now, amiodarone, on the other hand, can be used for this one, but it is not the first choice. Usually when we think amiodarone, we think of VFib or VTAC. However, in severe cases when a patient has other heart problems, like left ventricular issues or failure, amiodarone might be a better choice for them. It has other properties that could help with this particular rhythm. This one has alpha and beta blocking properties, and it affects sodium, potassium, and calcium pumps. Because it involves all those pumps, it interacts with a lot of medications. So it's super important that if you're giving this medication, that you review all the interactions that could possibly happen with this drug, especially any drugs that deal with these sodium, potassium, or calcium pumps. Orally, this can be given orally as well as IV. Usually when it's first started, it's IV and in a hospital setting with cardiac monitors. But patients can go home on it orally, has a slow absorption, only about 50% of it comes across for bioavailability, and it has a very, very long half-life. One pill will last for 58 days, its effects. Can you believe that? That's a long time. 2 months almost. So because it interacts with so much and it impacts these pumps, it has a lot of side effects. That's, again, another reason why this is not the first choice drug. It can have pulmonary issues, neuropathies, hepatotoxicity, and the list just goes on. So it's very important that if you have a patient with any of these conditions, that you need to review that and ensure that this is still the correct drug for them. Cost? A little bit cheaper, not much cheaper than the sotalol, so they're about comparable. And again, we're trying to restore normal sinus rhythm with these medications so that the patient can get a good squeeze on the heart, generate good cardiac output, and feel better. Of course, prevention is best, taking good care of ourselves, exercise, eating right, reducing our stress, all to have good cardiac health can prevent this. And a lot of times after patients have developed this, they are advised on how to live a healthy lifestyle to prevent further damage to their heart. Thank you and have a great day.